It happened in a meeting last month. You laughed too hard and felt it. You haven't mentioned it to anyone. You've started choosing seats near bathrooms and you've stopped jumping on trampolines. This is one of the most common things that happens to the human body, Shekshaw, and one of the least talked about. Here is why it happens and what actually helps. Stress urinary incontinence affects roughly 1 in 3 women and a significant number of men, particularly those who have had prostate surgery. The word incontinence makes it sound like a disease. It is not. It is a mechanical issue with a muscle group that can be addressed directly. The reason most people never fix it is because nobody explains the mechanism clearly enough for the fix to make sense. Your bladder stores urine and releases it through the urethra. The urethra is kept closed by two mechanisms: an internal sphincter that operates automatically, and the pelvic floor muscles that provide external support and compression. When you laugh, cough, or sneeze, you generate a sudden spike in intra-abdominal pressure. This pressure pushes down on the bladder. If the pelvic floor muscles are strong enough, they contract reflexively to counteract the pressure and the urethra stays closed. If the pelvic floor muscles are weakened through pregnancy, childbirth, aging, hormonal changes, or simply never having been trained, the reflex contraction is insufficient. The pressure wins. A small amount of urine leaks. Here is the part most people miss. The pelvic floor is a muscle. Muscles respond to training, and the exercises that rehabilitate it are not complicated, but most people do them wrong. Primary cause: pelvic floor weakness. Pregnancy and vaginal delivery stretch and sometimes damage the pelvic floor significantly. But this is not exclusively a postpartum issue. Inactivity, hormonal changes at menopause, chronic constipation causing straining, and obesity all weaken the pelvic floor in people who have never been pregnant. Secondary cause: urethral hypermobility. In some people, the urethra itself moves too freely under pressure rather than remaining in a supported position. This is a structural issue that a pelvic floor physiotherapist can assess and address. Contributing factor: bladder irritants. Caffeine, alcohol, and carbonated drinks can increase bladder urgency and sensitivity, making leakage more likely even with a mild pelvic floor weakness. Occasional leakage during extreme laughing or sneezing with no other urinary symptoms. Common, especially after childbirth or with age. Addressable: leakage that is increasing over time, occurring during low pressure activities like walking, or accompanied by pelvic pain or a sensation of pressure or heaviness. See a doctor or pelvic floor physiotherapist. The reason Kegel exercises don't work for most people who try them is not that they don't work, it is that most people cannot locate their pelvic floor correctly and end up training the wrong muscles entirely. Pelvic floor exercises, done correctly, are the first line treatment and they work. The correct technique: contract the muscles you would use to stop urinating mid-flow, hold for 3 to 5 seconds, release fully and repeat 10 times, 3 sets per day. The critical point: the contraction should be upward and inward, not a bearing down effort. If you are holding your breath, squeezing your thighs, or tightening your buttocks, you are not isolating the pelvic floor. A pelvic floor physiotherapist can confirm correct technique in a single appointment, and the difference in outcome is significant. Reducing caffeine by 50% and timing fluid intake so the bladder is not at full capacity during high-risk activities, exercise, long meetings are practical short-term strategies. There is also a less discussed treatment option that works for people who have done all the exercises correctly and seen limited results. And it is not surgery. Pessaries, small removable devices inserted to support the bladder neck, are an effective non-surgical option for stress incontinence that has not responded to pelvic floor training. They are fitted by a gynecologist or urogynecologist and do not require ongoing medication. Surgical options exist for severe cases and are highly effective, but are typically not recommended until conservative options have been properly exhausted. If your incontinence is significantly affecting your quality of life and exercises have not helped after 3 months of correct practice, ask for a referral to a urogynecologist. This is one of the questions people carry in silence the longest. If this gave you something useful, subscribe. One honest answer every week. Leave your question in the comments.